form of a tic in their lifetime. So that is more than any other pediatric disorder, like more than asthma, more than epilepsy, anything. 15% of kids will have tics at one time in their lifetime. So it is usually said tic disorders, on the other hand, not tics. Tic disorders are about 8 per 1,000 among school-age children. But these are for tic disorders. But if you take just tics, they are very common. Like in other neurodevelopmental disorders like autism and ADHD, tics are more seen in boys 2 to 1 compared to girls. And they usually begin before the puberty. So let's watch a video of some tics. In the past, we used to give these videos for the final year OSCE. Now we have changed to MOCI. But it's better to have idea because you can easily recognize these children in your practice in 2 years' time. Right. So if you can't hear the sound, please let me know. First, let's look at forceful blinking, where the child repetitively blinks. Apart from forceful blinking, there can be different types of eye movements, like looking upward. See, the child is like eye movements are upwards. Or they can be seen pouting. Sometimes these can be mistaken for behaviors that are inappropriate. So maybe teachers will think the child is trying to be mischievous. And nose wrinkling. And this is a very common one in Sri Lankan kids, facial grimacing. And many primary school teachers write letters saying that the child is making funny faces at them. Then fist clenching. You can closely see that the fists are getting tightened. Shoulder shrugging, very common among Sri Lankan children. Head nodding or head jerking is there also. We see in some other neurodevelopmental disorders like autism as well. And sometimes it is difficult to differentiate. So there also can be head shaking to sides. Also, tics can be sometimes seen in lower limbs, but it is more usually seen in the upper part of the body. So let's look at all the tics we have seen up to now are simple tics. Now let's look at some complex tics, which involve several muscle groups. So sometimes they may look like mannerisms, like they have some purpose, but they don't have a purpose and they're only complex tics. So these are all complex motor tics. So at the beginning of the video, what we were seeing were simple motor tics. So sometimes simple tics combine into a complex tic. So there here two simple tics have combined each other with grimacing and head nodding. Apart from motor tics, sometimes there can be vocal tics as well. Frequently, parents mistake this for kata or penis, or they will say they have allergic rhinitis. This is frequently mistaken by pediatricians for asthma, coughing, repetitive coughing. This is quite common among Sri Lankan children. Right. So first you saw simple motor tics, then we move on to complex motor tics. Then there were combination of simple tics making more complex motor tics. Then there were frequent vocal tics. Let's first look at the Tourette's disorder, which is the usual chosen disorder usually for SCQs. If you look at the past papers, you will see there has been many SCQs on Tourette's disorder. So for Tourette's disorder, the child should have vocal and motor tics, but there should be at least 2 motor tics. Symptoms should last for more than 1 year and they should start before the age of 18, and they should not be due to any other substance or a medical condition. Certain autoimmune conditions like SLE can give rise to tics. Certain medications like Ritalin or methylphenidate given for ADHD can induce tics. In that context, it is not considered a tic disorder. Then the other type of tic disorder is the persistent motor or vocal tic disorder. So they either have motor tics, motor tic or motor tics, or they have a vocal tic or vocal tics, not both types together. They should be lasting more than 1 year and starting before the age of 18, and should not be due to a use of substance or medical condition, and there have not been a past diagnosis of Tourette's in them as well. The provisional tic disorder, that is the short-lasting one, they have either motor tics, motor tic or motor tics, vocal tic or vocal tics. But the symptoms last less than 1 year. At the duration of 1 year, the diagnosis of provisional tic disorder will change over to persistent motor or vocal tic disorder. And same is applying here, should be starting before the age of 18 and should not be due to a substance or a medical condition. So it is very easy to remember tic disorders from the DSM-5 criteria, but if you look at the ICD-10 criteria, because usually for adult psychiatric disorders you read the ICD-10, they have a similar kind of classification. So transient tic disorder, is similar to professional tic disorder, which lasts less than 1 year. Chronic motor and vocal tic disorder is very similar to persistent motor or vocal tic disorder. And combined vocal and multiple motor tic disorder or Dila-Tourette syndrome is similar to the criteria in DSM-5. So what are essential MCQ points? A tic is an involuntary, rapid, recurrent and non-rhythmic motor movement. So in a true and false question, we will ask a tic first. Voluntary, it's false, it's involuntary. Long-lasting, it's rapid, recurrent, repetitive and non-rhythmic. So remember these essential features of a tic. Sometimes your adult patient in the long case may have tics with another psychiatric condition. So they can be suppressed for a period of time with effort, and usually the simple motor tics are more seen than complex motor tics. Another MCQ point. So compared to complex motor tics, simple motor tics are more common. So also, so you can see according to the ICD-10, they say 1 in 5 kids show transient tics at any time. That is 20% of kids usually taken at 15% of all kids will have tics at some point in their childhood. So it is more common in boys, and usually in tic disorders, a family history of tics are present. But usually parents would have forgotten that they had tics when they were children. Usually they would say no. But in other countries, because they have what we call home videos, that the parents make videos of kids when they are small, it can be observed in all videos when the parents were kids. So transient tic disorder is very similar to the DSM-5 provisional tic disorder. It is 12 months, less than 12 months, and the chronic tic disorder is more than 1 year. And Tourette's is almost similar to the DSM-5 criteria, where there should be at least 2 motor tics, at least 1 vocal tic, starting in childhood and not due to a substance or a medical condition. So there are classifications of tics. It can be simple tics, which last for a very short duration. Good examples are forceful eye blinking and shoulder shrugging. Or there can be complex motor tics or vocal tics, which involve several muscle groups. They last longer, and they are usually combination of simple tics. And sometimes you may think they are purposeful movements, like the child is trying to either comb their hair or pick up something, but they are not. Then a common MCQ topic usually special features in Tourette's. These are special complex tics that are seen in Tourette's disorder. They are very classical and they are very commonly used in Hollywood movies. Echolalia is repeating the last word of someone else's sentence. Echopraxia is imitating another person's movement. Palilalia is sometimes repeating one's own sounds or repeating a syllabus. Copropraxia is making obscene gestures, and coprolalia is usually uttering obscene words involuntarily. So we have several such kids in our clinic. So it is very problematic in the school, because suddenly in the middle of the class, when everybody is listening to the teacher, the child would utter obscene words. They are not voluntary, they are involuntary. Usually tics start around 4 to 6 years. Then they start increasing severity, causing severe concern to the parents. And they reach severity in the early adolescence. Then gradually they start dropping in severity, and usually by adulthood, many have very low amount of or reduced frequency of tics. But unfortunately, some will continue to have symptoms even in their adulthood. So what are the factors that could lead to children having tic disorders? So sometimes, because it is very common, commoner than any pediatric disorder, sometimes some transient tics can be worsened by child's emotions, like child feeling anxious or excited. Sometimes, especially grandparents may criticize the child. They will say, they will ask the child to stop doing it. Like then, child may have a exacerbation of the symptom. Sometimes children with tics may observe similar behaviors or gestures in other people's, and it may also increase the prevalence of tics. That is why sometimes parents say, මෙයාව මේ විශේෂ පන්තියකට දැම්ම ටික වෙලාවකට එතන ඉන්න ළමයි කරන ඒවා දැන් මෙයා ඉගෙනගෙන කරනවා. So actually they are not long lasting, but temporarily tics can increase by seeing other people doing. Sometimes they are seen as purposeful, sometimes it can lead to problems with teachers. Also, certain families have rare genetic variants that lead them to have Tourette's disorder, and obstetric complications, older paternal age, lower birth weight, and maternal smoking are associated with tic disorders in children. So what are the other disorders that can be seen as tic disorders? Obsessive compulsive disorder. Because sometimes compulsions are repetitive. Let's say a small child is frequently and repetitively washing hands. Is this a complex motor tic or a compulsion? Here what we need to know is tics are involuntary, but the compulsions are voluntary and cognitively driven. Then medical issues. Sometimes chorea, dystonia, and motor stereotypes can occur with medical problems like autoimmune conditions and metabolic conditions. Sometimes tics are caused by substances or medications like methylphenidate given for ADHD and may be induced by cocaine. Sometimes tics are seen transiently with impulse control disorders. So impulse control disorders mean where there is inability to control certain movements. So one of the commonly seen impulse control disorder is trichotillomania. Trichotillomania is the persistent hair plucking disorder where children pull their hair and sometimes they present with a large patches of hair missing on the scalp. And skin picking and nail biting are also in some impulse control disorders. When treating tic disorders, we have to identify what is a premonitory urge. So it is usually recognizable in all the children because smaller kids can't explain that. It is a sense of discomfort you get just before the tic. So when you don't have the tic, this uncomfortable sensation grows in time, and ultimately when the tic happens, this uncomfortable sensation goes away, giving a relief. So with the tic, the tension or the discomfort will reduce. Small kids will describe it as an itchiness in the eye or a discomfort or a pain in the eye or pain in the shoulder, and when the tic happens, it reduces. So this because of the premonitory urge, when the children can recognize the premonitory urge, some older kids usually can stop the tic happening. That is why it is said that tics are not completely involuntary. There are some semi-voluntary component. But if a true and false question comes, tics are involuntary, you should put it as true. So what are the complications of having a tic disorder? It can lead to social isolation due to the bullying and harassment. And sometimes it is very severe. Some people fail to complete their day-to-day work. Sometimes it could lead to parental conflicts and getting bullied by peers. Sometimes it causes significant psychological distress for the person and the parents. Rarely in Tourette's disorder, when they have very severe motor tics, it can lead to injury to the eye, fractures and neurological injuries with neuropraxias and nerve injuries. Tics are usually comorbid with other disorders, especially with OCD and ADHD, and also because of the long-lasting nature, also anxiety and depression can be seen with tic disorders. Because tics belong to these impulse control disorders where people can't control their behaviors, tic disorders are also associated with substance use. So usually people who take substances have impulse control problems because they can't postpone their need for a primary gratification. Primary gratification means need to obtain something they like instantly. Because of that, the people with tic disorders may have comorbid substance use problems. So this diagram shows how these symptoms are overlapping in Tourette's. They have tics, they have obsessions, they have behavior problems and aggression, and they have inattention and ADHD. So when you are writing the SCQ answer for a Tourette's SCQ, please write that you will screen for comorbid symptoms like inattention, obsessions, and anger, and then you will also address those problems. How do we manage children with tic disorders? First, as I said before, 15% of all kids will have a tic. So if it is transient, lasting less than 1 year, and not affecting the function, academic work of the child, you can reassure the parents that we can watch and wait what would happen. Then we have to explain to the parents that this is not a serious neurological problem and it will most probably reduce in intensity in the middle and late adolescence. And the tic should not be considered as a voluntary movement and the child should not be punished. Sometimes you would have to write letters to the school teacher stating that these are not voluntary behaviors, especially when they have facial grimacing. Usually, non-pharmacological measures are the priority with relaxation training, habit reversal therapy, and combined behavioral intervention for tics. So habit reversal therapy means when the kids are older, when they are able to recognize the premonitory urge. Premonitory urge is the discomfort the child feels just before the tic starts. So usually this premonitory urge disappears when the child has the tic. So in habit reversal, we train the child to recognize the premonitory age. For example, if they have forced eye blinking, they will say, my eye feels very painful or my eye is itching. Then I feel like blinking. So then you ask them to do what we call a counter response. Counter response is an action opposite to the actual tic. So rather than blinking it, we ask the child to close the eyes very forcefully so the tic can't happen. So that is called habit reversal. So when you combine relaxation techniques with habit reversal, it is called the combined behavioral intervention. When kids have persistent tics, despite psychotherapeutic intervention and despite and having severe symptoms and functional problems have started and the child is not willing to go to school, we start them on medications. Usually the preferred choice is low dose second generation antipsychotic like risperidone. Also haloperidol, pimoside, which are typical antipsychotics can be given, and also aripiprazole, another second generation antipsychotics are given. So usually risperidone, aripiprazole, haloperidol and pimoside are the preferred antipsychotics usually given in very low doses. Also, we also use alpha-2 agonists like clonidine and guanfacine, which can be helping to tics and usually do not have side effects of antipsychotics. So clonidine and guanfacine are two alpha-2 agonists that we use for kids with tics. So before we finish the first lecture, before we move to the second lecture, let's watch this video that explains a true story, but it's kind of enjoyable to watch it. Just have a look.
Hello. My name is Pete. I have a problem that maybe you have heard about, maybe you have seen, and most likely you find funny, annoying, or creepy. I have Tourette's syndrome. I'm not ashamed of it. I am accustomed to it. I want to tell you how I found a way to make it my advantage rather than a problem. I was an absolutely normal kid until one morning when I woke up and had an urge to twitch my head for no reason. And then another time, and another one. I was standing in the center of my room, doing strange movements, and couldn't help it. Okay, I thought, maybe it's some muscular spasm, and it will pass. It didn't pass. In several days. Even worse, I got a couple of other symptoms, like raising my hands, winking, and the worst, I had to squeak like a pig, like this. From time to time, I don't know why. Of course it became pretty visible, and I came to my parents pretty stressed. They brought me to the doctor at once, and that's where I found out I was diagnosed with Tourette's syndrome. I had never heard of that before, and believe me, if I had seen a person with these symptoms before, I would laugh or be disgusted. Now I had to present myself at school and explain that that's what I would look like for the time being. I was only 10 at the time. I still remember what it feels like standing among my classmates and saying I have a condition now, being in constant movement, and my classmates laughing at every single tic of mine. Okay, I understand that it looks like I'm having fun, but believe me, it's not pleasant or entertaining at all. Should I say that no one actually understood my problem, and everyone just thought that was my weird way of expressing myself. That was how I got isolated from everyone. No one wanted to be around me anymore, and the teachers actually didn't try to give me any support. Even worse, I remember once my teacher got irritated at my winking. She thought I was just making faces and put me in the very back of the room, away from everyone. There I remained, isolated both physically and psychologically. Unfortunately, I couldn't exist there unnoticed because I was making these sounds and movements that irritated everyone even more. I got to know some other guys with Tourette's. The idea was that I wouldn't feel so lonely if I got to know other people with the same problem. Unfortunately, Tourette's is tricky because when you see other people's tics, your own tics become worse. And even if such a situation can look comic in a way, all these tics are very tiring and debilitating. Thus, I came out really exhausted out of these meetings and tried to avoid other Tourette sufferers. In the meantime, the situation with my tics was growing worse. More movements added, more sounds, even abusive language. And after all, I came to my mid-teens looking like a swearing perpetual motion machine in deep depression. I was browsing a lot of web at the time, as online, no one was disturbed by my tics. Once, I came across that video of a Tourette guy who was singing at The Voice, and he was so flawless. Beautiful act without a single twitch. You know, I thought, maybe Limelight can distract you from this, and you can just perform, not thinking about being interrupted by some tic. I had an idea that maybe I could give it a try, and I even knew what I could do. I've always been quick-witted and had good sense of humor. I could maybe try a couple of times to make stand-up comedy bits for a small audience, just to come out of the house a little bit. I immediately sat myself to write punchlines that even made myself laugh. It was so exciting to see that I completely forgot my depressed state and was just taken by the process. Thing is, my Tourette tics may be pretty amusing if seen from the outside, and added to the comic monologue. The effect was hilarious. As far as I'd never been ashamed of my state, I managed to spot some really funny moments of being a Tourette patient. Small misunderstandings, enigmatic winking to everyone, all this stuff. And what I wanted to tell people was that having this condition is not a stigma. We are not retarded or anything, just regular people. I managed to make my first show surrounded by Tourette patients. I thought that I would see first if they would appreciate my comic bit, because they understand me like no one else does. The effect was even better than I expected. I got a standing ovation, which was a bit of an overstatement in my mind, but still pleasant.
Right. This shows a true story of a teenager who has Tourette's, very disabling condition, and his symptoms did not reduce with his age, but he used another way of expressing himself so he can cope with the extreme psychological distress. So in Sri Lanka, when they have severe Tourette's, it's very disabling and very psychologically traumatizing, especially for the parents. And 2 days back, I saw a 5-year-old boy with severe shoulder shrugging, as like he's almost like jumping from a chair. It looks like he's jumping on top of the chair, but actually he's having tics, and investigated by pediatricians with MRI, brain scans, and so many blood investigations, that he's slightly improved with medications and psychotherapy, but we'll see. And thank you for sending the message about the famous movie Hitchki. Yes, that is quite true. Where Rani Mukherjee plays a role of a teacher who suffers from Tourette's disorder. And when you have a break, maybe you can watch that movie as well. So there's another question. So how long we must continue the pharmacological therapy once we start them with the patient? So that is a very difficult question to answer, because there is no such duration recommended by the international guidelines. So what we usually do is, when we start the pharmacological management, we say we use it in phases. We say, okay, let's start this and let's see how it goes. If the symptoms reduce and it comes under lot of control, we stop the medication, telling the parents that, yes, by stopping the medication, the symptoms can come back, but don't worry, the medication is not a cure. Medication is just giving a control to the child. So there is no indicated one duration. So usually we say, okay, let's start risperidone 0.25 milligrams at night for 3 months. With each month, with the evaluation, let's see whether we need to continue or not. The next question is, in Sri Lankan school, is these kind of kids are identified and sent to psychiatrists? I haven't seen. Yes, so I think last Monday clinic, I had 2 referrals from teachers. They knew that this is a tic disorder. So usually, because of the transient tics, usually teachers miss them and they do not care about these changes. In Tourette's or persistent motor tics, they may identify and they usually know that this is a child psychiatric condition. Usually teachers who have no idea at all, usually they do not recognize and they do not refer. What are the disorders have bad prognosis? How do you differentiate them? So usually Tourette's disorder, the symptom severity is higher. There is no direct comparison between persistent motor tic disorder and Tourette's, but usually the severe patients have Tourette's. So usually you can take Tourette's disorder, people have a worse prognosis because usually in Sri Lanka, all the people who have long-lasting symptoms into their late adolescence usually have Tourette's. How do you differentiate from basal ganglia disease? Both seems involuntary. Very good question. So last week there was a referral from the pediatric clinic of a child with chorioepitoid movements. Sometimes the movements look like tics, sometimes they look like shoulder shrugging, sometimes they look like chorioepitoid movements. But for a pediatric neurologist, we don't have a pediatric neurologist in the faculty, but we have a pediatric neurologist in the hospital. A pediatric neurologist will say, okay, this is chorioepitoid movement and this is clear. Okay, that is why we are diagnosing basal ganglia disease. But in some kids, they have both. So I think about 2 weeks back, a child who has chorea and tics. So I think he's having autoimmune condition. I cannot remember. So when he was started on, I think aripiprazole for tics, actually his symptom severity reduced, but his chorioid movements persisted. They did not respond to the aripiprazole antipsychotic. Can you send the lecture notes of these lectures? Yes, I will email them today afternoon.
Physically. Hello.
Right. So we finished the first lecture. We will start the second lecture on intellectual disability in 5 minutes time.